Lucy Slater is the Senior Director of HIV, STI, and Viral Hepatitis at the National Association of County and City Health Officials, or NACCHO. She is a public health program leader with 30 years of complex, mission-driven program leadership in the nonprofit and government sectors. Lucy created a federally mandated statewide community planning effort to provide meaningful engagement of the most impacted communities with the state government in the prioritization of HIV prevention interventions and allocation of HIV resources. And next to her, we have Laura Guzman, who has been acting director for the National Harm Reduction Coalition since January of 2023, after joining NHRC in 2020 as a senior director of capacity building and community mobilization. She is a human rights activist, I can attest to that, a nonprofit leader with 30 plus years of experience serving, building capacity and organizing across communities in the interest of harm reduction, homelessness, health, and housing. Laura is passionate about community participatory processes that include and elevate the voices of people impacted by poverty, racism, the drug war, immigration laws, and homelessness as a path to redirect and develop resources and services relevant to the community she serves. And next to Laura, we have Dr. Stephen Lee. He is the Executive Director of the State and Territorial AIDS Directors, or NASDAD. Dr. Lee oversees, woohoo! We'll give you a woohoo. Dr. Lee oversees healthcare access, prevention, hepatitis, drug user health, health equity, policy and legislative affairs, and health systems integration programs, and on the side, NASDAD operations. Dr. Lee has expertise in program and organizational management with a practical policy and program implementation perspective. And then next to Dr. Lee, we have Kathryn Cates-Wessel, who has over 30 years of experience in substance use disorder administration, coalition building, medical education and policy. She is the Chief Executive Officer of the American Academy of Addiction Psychiatry and Principal Investigator and Project Director of several federally funded grants, including the Providers Clinical Support System and the State Opioid Response and Tribal Opioid Response Network, and the Minority Fellowship Grant recognizing and eliminating disparities in addiction through culturally informed healthcare. Next to Kathryn is Major General Barrye Price. He is the president and CEO of CADCA, which stands for the Community Anti-Drug Coalitions of America, but are recently rebranded as, I updated this, General Price, Community-Based, Advocacy-Focused, Data-Driven Coalition Building Association. Let's clap for CADCA, you guys.
Well done.
CADCA announced that this January at their annual forum, so I wanted to make sure I got it out in there. And then last but not least, a great friend of ours at the Collaborative, very long-time friend, Erin Williams, who is a senior advisor at the National Council for Mental Well-Being with over 20 years. We have to say that now, Erin. We've been working together, all of us, 20 years of experience, providing training and technical assistance in the field of behavioral health services with an emphasis on substance use treatment, prevention, recovery, workforce development, and the implementation of evidence-based practices in clinical settings. Mr. Williams has developed tools, resources, and provided subject matter expertise on substance use topics for diverse stakeholders, including federal grantees, rural health providers, federal program staff, and other community stakeholders, as well as Holly Hagel and Lori Crom. We're all good friends. So thank you today, and I'm just excited to hear what you have to say about what are the solutions we can implement.
Thank you so much, Holly. Thank you.
Thank you.
So I'm going to be helping out with moderating our session, and all the panelists agreed that we just really want to kind of be up here and in the spirit of a fireside chat talk shop. And so we planned a few questions really as talking points for us to kind of get going, and then we hope to dive into some discussion, and then also, of course, to include all of you in that discussion. So we're going to start out with Lucy, and for our first question, asking, how does your organization support a syndemic approach, and what are the benefits to your constituents and members?
Great. Thank you very much. for the challenge of having to kick this off. A bit nervous about that. So NACHO, as we've already discussed, is a National Association of County and City Health Officials. And so our constituents are really local health departments. And local health departments are really the folks who are doing this work on the ground. They are, along with the community-based organizations and our federally qualified health centers and other folks, doing the day-to-day work of doing public health at the most grassroots level. And they do public health work across the entire continuum, from soup to nuts, environmental health, immunizations, maternal child health, preparedness, and then also some of our STI, our hepatitis, HIV work as well. And so they really are already doing syndemic work. Some of the local health departments are huge. You got your New York Cities and your San Franciscos, and very well resourced. But most of them are quite small. Many of the more rural local health departments, only 2 or 3 folks. And so they were already figuring out ways to combine all of their work and deliver services syndemically. So they're doing your one-stop shopping, they're doing mobile health clinics, they're figuring out patient navigation systems, they're doing referrals and all of that. Their challenges are funding, their challenges are staffing, and their challenges are the policy and the political environments that they're working in. We recently did a survey of our local health departments and discovered that the people that they really want to be serving, that they're not able to reach, are sex workers, are the homeless, are folks in rural areas, are refugees and immigrants and migrants, and people of color. And so, little tangent here, but what that says to me is our local health departments really, really need help and want to figure out how are we going to address social determinants of health. And we've already had this conversation about, social determinants of health are key to a syndemic approach. And I think one of the challenges that they face and that NACHO faces, and perhaps other public health organizations also face, is that, our remit is to do public health. That's our mission. And we know social determinants and racial equity is a part of it, but we're not funded to do that. We're funded to do public health work. And so it becomes a little tangential. But what I want to say is that racial equity, social determinants is fundamental public health intervention and fundamental strategy. And so what I want to share with you is a little story. I was at the North American Refugee Health Conference last week in Calgary. And we had a presentation from a former government official from Germany. And I don't know if you remember, but a couple years ago, Germany was one of the countries that accepted 1.1 million refugees during the recent refugee crisis. They were the only Western nation in the top 10 countries accepting refugees at that time. And the presenter started out, and the first thing he said was, we never could have done this if we had not had a Truth and Reconciliation Commission in Germany that looked at our history and had a whole society approach to how are we going to turn away from the harms that we have done and be different in the future. And so I think that has to be the first thing that we as public health organizations say about syndemics as we move forward. What is our history? Can we face the truth about our history of genocide and enslavement? And let's keep acknowledging it. And I didn't even get to approaches yet. Do I have a couple more minutes?
Yeah.
Okay, good.
Yeah, sure.
All right. So that was a bit of a rant, but I think it was important to say. So what does NACCHO do as an organization to really try to support syndemic approaches? And I would say there's two major things, and I'm sure all the other folks on the panel will say the same: structures and partnerships. So we're really fortunate at NACCHO that we're an organization that supports local health departments across, as I said before, the public health continuum. So we have teams at NACCHO addressing environmental health, preparedness, maternal child health, immunizations, infectious disease, all of that. And so we have deep roots, deep connections across the entire public health field, and a lot of subject matter expertise. Our challenge is the same as everyone. Our funding is siloed. Our projects are siloed, and so we have to be extremely intentional about how we go about working with each other, but that is one advantage that we have. So, for example, and you saw my title is Senior Director of HIV, STI, viral hepatitis, harm reduction, and now actually refugee and migrant health. So we're getting all of it into one little team. So we're able to really draw upon those expertise to do some innovative projects. And a couple of examples, right now we are working to support STI clinics to think about how they can integrate harm reduction services. And simultaneously, the other way around, we're supporting harm reduction services to look at how they can integrate STI services. And that's an evaluation project that will generate some best practices that we can replicate and scale up other ways. Another example, just in a sort of emergency response, in our MPOX response, we were able to pull together expertise from our STI team and our HIV teams that could really draw upon our understanding and our connections with LGBTQ communities, and how messaging needs to happen within those communities. We pulled those together with our preparedness team and our immunizations team to be able to really do a sort of broad response across local health departments to the MPOX emergency. So that's some ways our structures really help us. The other thing I really want to talk about is our partnerships. So we're able to pull upon all of the partnerships that an entire organization has and our sort of gravitas, as it were, as an organization that represents local health departments to really facilitate collaborations. So recently, for example, we pulled together a tribal sexual health convening where we're able to bring together CDC, Indian Health Service, other national organizations such as ourselves, NCSD, Indian Health Board, the National Indian Health Board, regional Indian Health Boards, and then our members who are also tribal health departments. And be able to have, some of those people had never been in the same room together before. So really be able to have some intensive conversations about funding, about the major challenges that tribal communities are experiencing around congenital syphilis, and how all of that relates to rural health challenges, politics and race and health equity, and so on. One last thing I would say, because I know I'm taking up a lot of time, but just to acknowledge that the partnerships are not just internal and between local health departments, but between all of our national organizations as well. And so we have strong partnerships with folks on this panel. I want to shout out to NASDAD, to the Harm Reduction Coalition, NCSD is in the room, and so on. They have, even though they're subject-specific organizations, they have deep roots in those subject matter areas and deep connections, and they bring gravitas to a collaboration. And so we are able to really do things together that we would not be able to do individually. So for example, we had NCSD, NASDAD, NACCHO, AIDS United, and the Northwest Area Indian Health Board come together to do a really insightful and impactful webinar series on syphilis and drug user health, and that was able to reach constituents across the public health continuum. Okay, I got my 1-minute warning, so I'm going to stop there. And apologies if I took up all your time.
No, that's great, Lucy. Thank you so much. And we're going to go ahead and move on to Laura for Laura's question. And so, Laura, we were going to ask you to talk a little bit about some of the barriers and constraints to integrating a syndemic approach. And maybe if you could talk a little bit about what you've done to address those barriers.
Thank you, and good afternoon. It's my first time in a national panel, so I'm frozen and excited. I wanted to start by saying that in some ways it's interesting, the movement, the Hammer Action movement and the Hammer Action Coalition, which I now represent, we started with a syndemic approach in the 90s, in the mid-90s, when people living with HIV who used drugs were completely abandoned by government, whether it was federal, local, or state, and abandoned even by certain providers. And so it was rebels, I call it. It was people who used drugs. It was social workers. It was people with HIV who jumped to say, how do we support our folks to stay alive, to die with dignity for those that were dying, to have minimum access to respite or otherwise hospice as they died. So to me, this is very important because sometimes when people talk about harm reaction, they think that politicians brought it upon or public health. I just want to make sure that the record of the history goes to know that it was a syndemic approach. And that meant we were trying to make sure that poor people with HIV who use drugs were accessing Ryan White care dollars. In San Francisco, we had to actually form a task force that redirected care funds to the Tenderloin district, where Black folks and trans folks were dying without any money or access to the supports that otherwise the federal government was bringing. So that's, to me, goes to the heart of how we were doing syndemic approaches. And then I want to say we started discovering also that because we were serving a large number of injectors as they were HIV positive, and where we started to realize upon the very few programs that were testing that they were also HCV infected, actually a lot of our folks die of liver disease rather than HIV post-1996. I started working in 1995, so I was among one of those people that was trained by those amazing, I call them soldiers of harm reduction. And so that's when HCV started. I was in hepatitis C task forces in 1996, and we still don't have adequate treatment. Just to tell you, for those of you who were born in 1996, how old are we in this panel? But also just to reflect upon, and I'll talk in a second about infections and inequalities, because we talk about social determinants. I want to talk about inequalities. I want to talk about racism. I want to talk about the very things. I want to talk about criminalization, not of drugs, but of drug users. The criminalization of Black and brown folks. Those are the kind of things that are hard to talk in a syndemic symposium, but are equally important. I also want to say the harm reduction movement was the first to distribute naloxone in the hands of drug users. Can you see hands up? And we have a godfather who is in heaven. His name is Dan Biggs. And he was one of the first to bring actually naloxone from somewhere in Italy. He smuggled them. And actually, that's how it ended up somehow in San Francisco. And we started, the DOE project, which we oversee, 20 years ago, started actually doing community distribution of naloxone in the hands of people who use drugs. We were not giving them to the cops because the cops were not there to save anybody's lives. To this day, they don't do most of the reversals. People who use drugs do those reversals. So I just want to say, overdose interventions also came from the harm reduction movement and people who use drugs. And that is why we need to honor all that history in a syndemic approach as we look at solutions. I wanted to talk about infections and inequalities because when I talk about social determinants of health, I cringe. Perhaps because I was not born in this country. That is actually important because I have a different view. I see the way in which colonization, not only of third world countries, but colonization of Black, brown, and Native folks in this country, it also has a tremendous effect on the health of our people across the board. We're just mentioning some infections. The overdose epidemic is also related to the criminalization of drugs, the way that we cannot even talk about a safe supply, where other countries, which are not that radical, like Portugal, can talk about it, right? So we need to make sure to understand that the inequalities are deeply rooted in what I call a colonialist, and also, deeply rooted in our system of, capitalist, imperialist system of healthcare. And I think that that is important even when we talk about a syndemic approach. I want to say this because in some ways, when we talk about a no wrong door, people who use drugs and our marginalized communities within it, Black, brown, Native, queer, youth, unhoused people, every door is wrong in this moment. And I just want to pause for a second. And not because I say it, it's because they say it. And so part of the work, tomorrow I'll be talking about California, we've been polling, our research data was going to SSPs as partners in our California initiative, which I'll talk more tomorrow. But we make sure that participants on the ground told us how well the SSP, as we were enlarging the amount of funding, which many of them were operating for 25 years without a single dollar. We have heroes and sheroes and dayros, we call it dayros, on the streets of our cities that are doing harm reduction work without not only not being recognized, but also policed and mistreated. And so these are the folks that went to poll folks during COVID when nobody else was out there. And it was our participants that were telling us when we say, what about treatment? What about MAT? Even the things that people may be familiar with. I mean, most of the people say they will tell us the stories they went through every time they tried to enter a treatment program, every time they started methadone, they might have gotten the take-homes, and then the take-homes went away. How they were stigmatized because they entered the door to a program, nobody speaks Spanish. And guess what? They just speak Spanish. Or Black folks that go to public health departments or clinics or CBOs where there's no Black staff. So I'm just saying, the no wrong door approach will require a lot of effort that should also include BIPOC leadership, people who use drugs leadership in that design. Without it, we're not gonna change there are gonna always be wrong doors. So I hope I'm listing some of the challenges. And I know that I'm about to wrap up. What I wanted to say in closing, and the reason why I bring criminalization is we were doing this amazing initiative. Tomorrow you'll hear more about it, so it's a little snip, in California where we, for the first time ever, organized for and got the first word, $14 million for 3 years, where we were able to fund SSPs. We actually acted as grant makers in addition to our historical technical assistance and capacity building, and we added evaluation. And with that initiative, we had to show that's what the politicians wanted to know, how much treatment people want. And so I know that substance use disorder is in the syndemic approach. We need to add overdose. We need to add overdoses because you don't need a substance use disorder to overdose, right? Okay? And the reason why I bring criminalization back is at the same time we're doing amazing work, our SSPs were getting challenged from NIMBYs, which actually we're starting to trace some of this comes from really high money, Republican money, some Democratic high money, that are really funding NIMBY groups to sue our syringe service programs that have so little resources to operate. And so we went ahead and actually changed the laws in California so that they cannot use Environmental Protection Act to go against the SSP. We still got sued. Santa Cruz Needle Exchange has just been sued. Actually, they appealed the lawsuit and they're suing the state of California as well as the SSP. So what I'm trying to say is we are at a particular moment as we're talking about a syndemic approach where I feel government has a high responsibility in the high places to also name those barriers that actually get our people, our workers, our workforce being tired, being devastated, being exhausted to not only stay out there to save our communities' lives, but also to defend from meaningless, brutal, criminal acts of what I call, defying the needs of our people to stay alive. So I think there's a lot of many conversations we'll have, and thank you for the opportunity.
Laura, thank you. Thank you so much. Laura, thank you for that. And Stephen, moving on to our next question. When you think about the language around syndemics, or using a syndemic approach, what are the things that you think are important to consider?
Great. Thank you. Thank you for the invitation. And Laura, I just have to say, for someone who was anxious and nervous, you did a phenomenal job. And my quick tangent is that Laura and I reconnected yesterday after 25 years of not seeing each other. I started my clinical life in San Francisco in 1996, and Laura was one of the benefits managers that I worked with. I was an HIV primary care doc, so it was fabulous to see you. So first of all, quickly on NASTAD. So NASTAD is a membership organization similar to NACHO and others on the panel. We are an organization that represents governmental public health leaders in the HIV, hepatitis, STI, drug user health field. And we just updated our mission and values statement to really incorporate our commitment to ending HIV, but also impact the epidemics that impact HIV, hepatitis, drug user health, and other intersecting epidemics as well. And we also updated our mission to ensure that we're encompassing leveraging our community partnerships. I think this gave us really the opportunity to ensure that our membership is really, and NASTAD as an organization, is really leaning into engaging with communities. So as part of that strategic planning process, we created a Syndemic team. And actually, Boatima Interior Reed is here. Where is Boatima? Is leading that team. And Boatima is the equivalent of Lucy at NACHO, leading HIV, hepatitis, drug user health, prevention. Oh, there she is. Efforts. We take a really, to the conversation that we've been having so far, an equity lens to our syndemic approaches. So I'm going to skirt your question a little bit around language, because I'm taking advantage of Dr. Merman's earlier conversation about, I don't want to get bogged down in definitions and in language, but I do want to take something from Dr. Merman's presentation and run with, which is around his, he outlined in fact 3 components of syndemics. It's 2 or more diseases, made worse by contextual factors, social and contextual factors that then make those diseases worse. And so I want to focus what our membership is doing on the social and contextual factors, i.e., this is to Laura. I'm going to close your ears, Laura. It's the social determinants of health. So it's our membership is really taking a whole person approach that with a lens to really addressing racial inequities, the housing inequities, the mental health, substance use, and overdose. I am listening to you. And overdose issues. We're working on addressing the funding components and funding issues that's associated with it, the economic inequities, et cetera. And so some examples of things that our membership are doing is, I've got a list of things kind of organized in my brain. One is, and I think Lucy alluded to this, is around just planning, structure, staffing, right? So many of our members are really doing planning processes, strategic planning processes that take a syndemic approach, take an approach that incorporates the social determinants of health, take an approach that incorporates racial equity, racial inequity, housing inequity, economic inequities, and those are all parts of their planning processes. They are structuring and organizing their bureaus in a way that embraces a syndemic approach. So, and I think we have a colleague from Chicago who's here and I think is doing a session either today or tomorrow. And I think Chicago is a great example of where they've structured, they actually have created a syndemics bureau that incorporates many of the infectious diseases that impact drug user health, and others. And then on the staffing piece, many have created syndemic positions, syndemic staff positions, and a couple interesting things that I'd want to share is one of our members created a joint position with their substance use recovery unit that is half funded by that unit, half funded by the public health infectious disease team. And so that's creating that link between substance use and overdose prevention and then the infectious diseases that those individuals may experience. And another kind of creative staffing position are internal partnerships that some of our members are doing is really partnering with their Office of Health Equity within the Bureau to ensure that the equity pieces are infused into the programs that they're designing. Many are using a status neutral approach. The no wrong door, and we'll certainly take from Laura's most recent comments around what that means to the next level. Many are also looking at the data as a way of ensuring that they're addressing using existing resources, existing data platforms, and in thinking about how we can incorporate additional data to ensure that they're focusing on the right communities, the geographic communities and the populations at risk. But they're also looking at how they're evaluating their programs. And so what are they learning, and as they're implementing their programs, what are they learning to then be able to build on those experiences. And then the last quick thing I'd mention on our membership side is around funding. And many of our organizations, many of our member health departments are braiding CDC, HRSA, HUD, SAMHSA, state or city resources in a way that then allows for a comprehensive program. And this has been evidenced in a couple of states where they're then now doing grants to their community partners that are comprehensive grants. And so flowing that concept down to the implementing partner level. And then I'm just gonna wrap up to talk quickly about some of the things that we as NASTAD are doing at the Syndemic around Syndemics. I've mentioned our structure, I've mentioned our leadership with Guatemala, and then maybe the last piece I'd mention is our work as a Syndemic partnership between NASTAD, NMAC, AIDS United, NCSD, and the AIDS Institute, where as a partnership we are advocating across the federal government, and work, I think we meet with Jono probably once a month. It feels like once a month these days, and his team to really ensure that we are advocating for that broader inclusion beyond HHS of other federal government agencies within the Syndemic response. So thank you.
Great, thank you. Thank you, Stephen. So, Kathryn, next up on our panel, kind of thinking about AAAP, and thought maybe you'd share a little bit about the types of knowledge and training and resources that your constituents, your members, what are they needing, and thinking about that need to successfully implement a syndemic approach.
Let me just explain who we are. The American Academy of Addiction Psychiatry is also a membership organization, and it's for psychiatrists who are boarded in addictions, have been in existence for about 30 years. They're alone, they've been alone for a long time. And a lot of people, even in the medical field, didn't recognize psychiatry as medicine. They just write scripts, and recognize, oh, you deal with those people. So they've been dealing with stigma within their own profession for a really long time. So that's been an uphill battle because they've been working with a lot of the same people that all of you work with. So the stigma within the medical community, the general population, and the people that they treat. So a big challenge for them when I came to them was they're just trying to hold themselves up to keep up with the patients that they have and to try to get out there and advocate. But to get them to move out of their comfort zone to really promote mental health. And I think that gets lost way too much. We don't talk about mental health enough. And there are reasons why people have a lot of these issues and concerns. It's exacerbated because of their mental health. And so to have more of them to help them carry the load with workforce development, reimbursement that's reasonable. These are not people that make a ton of money. Yes, they do make more money than others, but in the medical community, they don't get paid to go out and do the things. For a long time, they were just doing what they did and not getting reimbursed. It's hard to engage people to want to come into that field. Oh, yes, you can come, but not make a lot of money. But you can transform people's lives. And I think that's a big part. Our tagline is translating science, transforming lives. And that really is the mantra of who they are. They're very passionate. But I did find when I came there, they were very insular. They're just talking to themselves. They're used to not really sharing with others because for so long they were just kind of shunned. And so I wanted to push them out of their comfort zone. You have to work with others, because if one of our priorities is workforce development, you're not going to do it just with dealing with people like yourselves. One, we can't get general psychiatry to even embrace it and require students to get training around addictions. Even with your own group, which is challenging, we have to get our members to advocate. It's hard. I know some of you won't believe this, but they're some of the most difficult people to get up and stand and wave a flag and say, we need to do this. They go, I'm not an advocate. I don't know how to do this. So that's really empowering them to say, you have the ability, you have to do this, because if you don't do it, someone else is going to do it for you. It might not be the way you want it. So that's been a big part of this, but also working with others out of your own discipline, working with social workers, working with dentists, working with pharmacists, and really moving beyond that has been a huge endeavor for us, but I think it's critical. And some of us were talking yesterday, having been in the field for a very long time, where most people didn't talk about substance use disorder or addiction. It was too shameful. It was a part of the disease. No one wanted to really, the anonymity of it was just the way it was. You either went to AA or it wasn't talked about. So now to have people talking openly from all different walks of life is just so reassuring. We're primed and ready for this. And so we wanted to reach out, and through SAMHSA's funding, initiated or filled their request, we didn't initiate it, carry out a couple of grants that I worked with quite a few of you, UMKC, the National Council, CADCA, NACO, NAZADAT, a lot of us. How can we come together? I'm a Southern girl. I was brought up, you can't do it all. When you come to Sunday lunch, you bring what you do best. My mother made the best fried chicken. Somebody else made the best, butter beans and corn, whatever it was, and the best sweet tea. That was very important. But you bring what you do best. You can't do it all. And all of us, I think a lot of times have spent too much of our time talking to ourselves and not taking that and getting courage and stepping out and say, hey, what do you got to bring to the table? And I think that's what's really been important and valuable for us in having the opportunity and having the funding from SAMHSA, which has been awesome, is to be able to say, hey, General, what are you folks doing over there? Let's work together. How do we be efficient? How can we be cost effective? How can we not compete with each other? Acknowledge, but define gaps. What's missing where? And people that work with me get tired of my comments of things about we're connecting dots. You're doing what, you're doing what. Let's don't duplicate things. It's too hard to get the money that we have. We don't want to waste it. So I think in a lot of ways, I didn't realize I was doing syndemic work, but yes, I have been for a while. We have, in one grant, it's only for health professionals. How can we pick up where the training for all health professionals lacked? We have mentorship, we have online courses. Everything is free, free, free. We have over 800 resources online. Yes, we provided the X waiver training, but now we're providing even more 8-hour training, which is not the X waiver, but we know people need more and more training and support just to know they're doing the right thing. So I think that's been really important, but we also reached out and we recruited 23 national organizations across of all the medicine to say, hey, we're here as your messenger and your partner. So they get a piece of the pie. They go to their constituents, because their constituents, the American Academy of Pediatrics, Emergency, National Association of Social Workers, American Dental, all of those places, they're going to go to them. They're not going to come to me. Addiction psychiatry, I wouldn't even think about dealing with those. So they go to the very people that they get their info. They've been validated and so forth. So they get money and they reach out to their folks. That's what we do on Providers Clinical Support System. Again, if you haven't used that, any health professional that you have, you need to go there, because this is where you can get the support one-on-one. We call it speed mentoring, where you just post a question and an addiction specialist gets back and respond. Or if you want to have something a little bit more intimate, you can have a dedicated mentor. And the second one was the Opioid Response Network, which quite a few of you are partners with that. We have 46 national organizations, and we went beyond medicine, because it's just not health professionals. It's prevention, it's treatment, recovery, Now harm reduction, we can actually say that, harm reduction. And how can we collectively provide technical assistance, training and education, but then also individuals. You want to come up and you want to put a request for training and education in your community, your tribe. Within 24 hours, you get someone to respond to you, and we provide the training to you at no cost. So those efforts coming together to build relationships is really about building sustainability. And I think that's what's really critical for all of us, is to have the courage to step out of line, speak up, because if you don't, someone else is, and it's going to go in a totally different direction. So I encourage you to think about ways we can all, and I've been sitting here filling my pockets with people's names. How about you? What about you? So don't get afraid if I come up and start talking to you. I'm really not that strange. But it really is important to help each other, because we're all dealing with a lot of things. People need respect, they need dignity, and they need to feel worthy. And I think those are the things that all of us have in common ground. So that's our common ground. And there are a lot of more things. We've been working with the justice. I know it's an inappropriate word, legal, law, judges. If we don't have them all understanding what's going on with the neurobiology of addiction, and people don't want to be addicted, they don't want to be sick, they're not high, what can you do? And it's pretty incredible. I'm seeing a lot of change within judges and probation and parole and other. I think we just have to take baby steps, but come together and really advocate.
Kathryn, thank you. And Kathryn, you bring us a great segue in talking about collaboration, and so we'll move to General Price. And so we asked General Price, what types of collaboration are needed to advance the health needs for communities using a syndemic framework?
Thank you, and I want to thank you all for this opportunity to share and for this remarkable forum. And I want to thank my long partner, Holly Hagel, and Kathryn from AAAP, and Orrin, because we actually did a publication together a couple of years ago on how to end the syndemic. But before I do that, I want to three administrative announcements. First is that it's raining outside for the first time in Kansas City in 6 weeks, and I believe it's only because I'm wearing suede shoes. Yeah. The other thing I want to tell you is don't worry about how much time I take, because Aaron and I have already had the conversation that I'm not going to leave him any time to speak. But he will put his notes in the chat, so. And third administrative announcement is that I want to say to my wife, who's a psychiatrist, and I hope this is being videotaped, that you're right, honey. I do have ADHD, because whoever's writing these notes on this thing is totally got me captured by, my attention is totally captured by these notes. And I don't see her writing right now, and so it's starting to make me a little nervous.
Where's Rosie? Rosie's back
Thank
there.
you for that. Thank you for that, Rosie. So last week, my organization, CADCA, which, as Holly told you, is community-based, advocacy-focused, data-driven, coalition-building association. And we did that. We took that anti-drug out because it was stigmatizing. We changed it from Of America because we're in 28 countries around the world, and we train in 9 languages. And I would tell you that we learn more from what we do internationally that informs what we do domestically than the other way. So last week I met with 2,400 of my best friends in Dallas, Texas, Grapevine, Texas, for our mid-year, and we just had a phenomenal time. And one of the things that our organization has done, and it's been just the last 3 years, is we embrace harm reduction now. Parts of it, not all of it, but we're growing, right? We're getting there. We are full continuum treatment and recovery, and to include prevention, but treatment and recovery. And then lastly, we're actually talking about it, and we're having hard conversations because we build coalitions. We have almost 7,000 community-based coalitions, which are 12 sectors, right? Kids, kid-serving organizations, parents, media, clergy, law enforcement, 12 sectors sitting around the table, and we teach them how to work collaboratively together to solve their own problems. And so all of our coalition, we say if you've seen one coalition, you've seen one coalition. Because when you meet with a coalition, their work is based on the surveillance and an assessment of that particular community. And all communities are not the same. They're culturally competent, and we teach them how to sustain themselves. But there's really 4 pillars that we focus on. First is advocacy. You know, we teach them how to advocate for themselves, not lobbying, because lobbying usually has a dollar associated with it, but how to advocate, how to use their voices with their local community leaders. And, oh, by the way, you want those leaders on the coalition. And then when they come to Washington for our National Leadership Forum, we have a Capitol Hill Day where members of Congress come over, both congressmen and senators come over, and they have an engagement with them, and then we send them over to Capitol Hill for sit-down meetings with their legislators. Key is that are the kids that we send. Last week we had more than 500 kids in participation, and they listen to kids, and so make sure you put kids out in front. Second, we teach them, we educate them. We teach them the art and science of prevention. Now, though our focus is illegal and illicit drugs, underage drinking, stopping underage drinking, and the cessation of all uses of tobacco, we found that after 6 months with this strategic prevention framework and the tools that we give them, you can overlay that model that we teach them on any scourge in the community, and they can solve it. We see in our coalitions, after 6 months after they graduate from the National Coalition Academy, population level change. There's no other program that can argue that. And we believe that we have a tremendous solution to use the opioid settlement dollars. So when you say, well, this really creates the best of all possible worlds for us at CATCA, because the greatest challenge has always been financial. They don't have the resources. And now communities are getting, our states are getting these monies, billions of dollars for 18 years, right? So there's no issue with same year money. You all know what that is. How many federales we got in here? Federal government people. Come on, you know what I mean? Raise your hand, don't be ashamed. Raise your hand. I was one for 31 years. Well, there's no issue with same year dollars, right? There's no issue with continuing resolution where you can't add things. You know, you can't have new spending, new starts, right, on things that weren't already budgeted the previous year, or truncated spending window. I'm looking over to see if Holly's giving me the hook yet. Or a truncated spending window where you only have 7 months or 8 months to spend the money. We know you can't build brick and mortar things with 12 months, right? And so the opioid settlement dollars provides that opportunity. Likewise, the opioid settlement dollars provides us an opportunity to train all of those coalitions that's been kind of dormant because their funding sunsetted. $270 for membership is a lot of money for a lot of communities. And we take that for granted that they have $270 to pay for membership. Well, we're asking the states now to pay for that with opioid settlement dollars. We're asking states to send 2 people from each group. We use this modality of train the trainer. We train the 2 primary people in the coalitions, and then they go back and train their community partners. Send 2 people to our National Leadership Forum to get the latest and greatest in the science from all the lettered agencies that work in this space. You know, to attend our mid-year where there's half-day-long training, more CEU credits, deeper dives into art and science and prevention. And then we also asking them to create coalition academies to meet people at their level of competence so that we can, if you look at coalitions across our states, they really blanket the breadth and width of our states. They're in every community, in every county in our country. And so I'm asking them, the states, to pay for them to go to a specific opioid-focused, three-tier logic model focused academy that we'll do for them, and then we'll kind of level state the competence in the state. Again, the training is based on an assessment of that particular community. And so we'll bring everybody up to a level of competence, and I believe that's going to be a game changer for our nation. And not asking the federal government to do anything, we're asking the states to do it now with these opioid settlement dollars. Final thing. This is remarkable. But if you want to go next level, you really have to have a convener at the national level. Somebody who lives and works in Washington, D.C. Somebody with relationship with the White House, executive branch, and the legislative branch, the Congress. Somebody with the gravitas who can go back and forth and work the DC magic. It's called Washington rules. It applies. And so when you say, well, years, that becomes weeks and days. How many of you have seen the movie Oppenheimer? Huh? Just came out, yeah. I'm surprised so many have seen it already. Well, there's a guy in that little known person in history that Matt Damon plays called Leslie Groves, General Leslie Groves. He's an engineer. He worked waterways in his previous life, graduate number 4 in his class from West Point. But he was the guy given direction over the Manhattan Project. He's the guy who picked J. Robert Oppenheimer, who was a physicist, to build the atom bomb. He had access, I'm talking about Groves, to the Secretary of Defense, to the President. That's a convener. That's a grand arbiter. That's somebody who can marshal resources. And that's the way that this syndemic approach takes off. And so I would just give you that as a Washington insider, and that's free. That's free chicken. Okay. Thank you, Rosie, for getting me up on the screen too. So, Aaron, I guess I'll leave you a little time.
Thank you, General Price. Thank you. Aaron, I'm guessing that deal wasn't exactly a mutual.
I think there were some points of disagreement on that.
Okay, all right. Well, why don't I just go ahead and ask you your question then, just in case there's some things you want to bring up for us, and I hope that you do. At the National Council, how does the organization use lived experience to inform syndemic approaches?
Well, so first I'll say thank you to all of you. Thank you to UMKC for convening this. Thank you to Holly for letting folks know that we are at 20 years in the field, so we can't, shave that down to save on our age. So before I get into the question, I think I want to talk just a little bit about the National Council for Mental Wellbeing. I say that because we changed our name 2 years ago from the National Council for Behavioral Health. And a little bit about our syndemic strategy. So I've been at the National Council for about the last 12 years, and through ATTC work and other work, been in a number of different mental health and substance use treatment programs across the country. The National Council represents primarily mental health and substance use treatment providers, so we talk to our members regularly. And for years, and I think this is borne out in many folks' work, one of the things that people will talk about, they have long been at the front lines of this sort of care. And often they've been asked to provide that care in an unfunded way in many instances. And the common refrain for a lot of providers is the idea that, they're helping people reduce or discontinue their substance use so they can die of another illness in 20 years. Or so that they can, know that someone needs other resources and they can, put in their, plan, and we hope they go see the doctor and have no idea whether they went or not. And they've been asked to work with folks in this way. And so as a part of the National Council's work and its, advocacy agenda, we've long advocated for the idea of whole person integrated care through some of the integration of primary care and behavioral health work that is still going on through SAMHSA and HRSA. And also in more recent years, our championing of the Certified Community Behavioral Health project, which more than 500 organizations now have that designation. The idea is that how can we pool resources, how can we give mental health and substance use treatment providers who are at the front line of this the resources to partner, to develop the relationships, to provide holistic services in ways that make sense. So we've continued to do that work, and our membership is in all 50 states, and I think we all know that is a pretty diverse membership and pretty diverse politically. And how do you create a federal advocacy platform for them? They have pretty diverse interests. But when it comes to this, they're pretty much in alignment. How do we get the services and resources we need? How do we provide a comprehensive care to help address these things in ways that sees people as whole human beings? So that's the big piece of our syndemic efforts. And in terms of the question around recovery, we have thought about this, I think, in some very positive and interesting ways. So we have a number of different projects now. We focused a lot of our efforts in the harm reduction space. We have partnerships with some of the folks on this panel. We certainly have had a long partnership with the CDC over the last few years and provided a number of resources and toolkits related to harm reduction. And as a part of that work, we've begun thinking about, how do we involve people with lived and living experience, not just in sort of the end work, but in the strategy and the planning and the actual formation of the projects themselves. We have a number of projects where we have people with lived and living experience who are a part of the advisory panel, who are helping us think about what actually are the resources we should be putting forward. What are the things that we should be doing that are most helpful in the space? The other piece of this, which I think is a really important piece, and is something that I think many of the folks in the room, I might suggest that we think about, is that you can't do this in a vacuum. As a part of your training or technical assistance efforts, you have to start doing some work internally to think about how you as an organization are actually engaging people with lived and living experience. So as a part of that work, over the last few years, we've done a number of things in thinking about that work. I think they're small steps, but I think they're steps in the right direction. One of which is that we have started a lived experience employee resource group in our organization, a place and space where people who have lived and living experience can talk, can share, can engage with each other, whether it is to put forward ideas for the organization or just to share with like-minded individuals or people with shared experience. And we've created that space within the organization. The other piece of this is we have tried to think about how we can diversify our own board membership. And one of the things we've done is we've actually added a member now who actually runs an RCO, a Recovery Community Organization, to our board. So part of this, I think, is an ongoing effort for us to think about, what our members need, but how we can involve people with lived and living experience, at the higher level of this conversation. It's one thing to have people at the front lines doing work, but it's another to have people in the boardrooms and engaged in some of the strategy, for people who look like them. And I think that's a big part of this work, and I think it plays into larger efforts around equity, diversity, and I'm happy that we're engaged in that and moving in that direction. So I think those are the things that we're doing sort of right now that I'm thinking of.
Thank you, Aaron. Thank you. So I've been informed that from my colleagues that we've been able to rob Peter to pay Paul in terms of some time. So we're gonna take a few more extra minutes and open it up to some discussion and questions with all of you. So Dina and Steph are out there. And if folks just want to raise their hand to let them know, they'll come to you with those mics.
Hello. I'm not a baby healthcare provider. I've been around many seasons. And I do remember when I was a baby healthcare provider that the basics of syndemic health were discussed and not working in silos and vacuums, et cetera. So that's been around many, many, many moons. As coming from healthcare family members, I remember those discussions at the dinner table as well. So I've heard it a long time. So my question to the panel and to you experts in this room, how do we really, this time, remove the vacuums, remove the silos, and create succession planning so that those coming behind us, those in schools, those out in the fields, on the streets, on the front lines, hear, understand, and grasp the messages in a systematic, strategic plan so we move forward. Thank you very much.
Was that a question or a comment or both? Okay. I want to take you upon the Hammer Action Workforce as an example. And the idea, it's interesting because we were talking succession planning last night after a couple of, can I say tequila? Yeah, it was tequila sunrises. It was him and I. But one thing I want to say with regards to the Hammer Action Workforce, with regards to SSPs, with regards to bringing, Black, brown, Native leadership to our work, it's hard if it's not resourced. So we don't have the resources to pay them well. We don't have the resources or the academies that we need to bring. And I've been hearing a little bit of CDC and folks talking about academies. We've been dreaming of academies of people with lived and living. I love your talk about lived and living, because sometimes when we talk about live expertise, we talk about past expertise, and hiring people who use drugs is not a priority or is against our HR rules. That means also it's strengthening our policies and procedures so we can not only hire but retain the folks. So we have a tremendous problem with generational divide. I'm old, as you can see, and you heard already. And so as we thinking about passing, that transition planning should include how do we hire, retain, and develop the workforce, our next generation, our next leadership. I'm real interested in particular, because we're talking about inequalities in this country, how do we do that with the folks, our youth of color, our black folks, our Native folks, our youth, LGBTQ, all the communities that are most impacted, and that will take effort. So I think your question is critical, because it's not about I made a succession plan, but rather what are we doing to really keep that backbone. So tomorrow we'll talk about in California, we had to really jump up to say we did this initiative, it was great, it was about to expire. And then all this money was gonna be put on naloxone by our governor. And it's like, hello, we love the naloxone, it's actually expensive, you only have one provider, and we have a workforce that we need to support. And that's just the tip of the iceberg. We just got enough money to continue, right? Hopefully expand, but I think there's a lot of work to do on that workforce that we're talking about, and to make sure that we know the next workforce is of that leadership of the people who should be at the forefront. So I love your question, comment.
And if I can, I just would emphasize Laura's point about organizations taking a look at their sort of HR policies and seeing whether or not they have barriers that are actually hindering their ability to hire people who are talented, hire people who have lived and living experience for roles that they certainly can play, and thinking about are there other barriers that prohibit some level of succession within organizations. I think that's a big part of this, even beyond just the grassroots work, but looking internally to try to understand where there may be gaps.
Stephen, I think you also wanted to add some comments, and then we'll go to another question.
Yeah, I wanted to add from the kind of my primary care brain a little bit to the conversation. Like Jono, I started my professional life as a primary care doc, and so have been thinking about this as just the way I do work as a primary care doc. And so part of the way I think we address kind of the succession plan is to incorporate, and by the way, I didn't learn about syndemics in medical school as a medical student. And so part of the succession planning of routinizing this is let's teach our young clinicians about this, whether it's nursing school, medical school, social work, pharmacy, the entire PA, nurse practitioner, the entire gamut of clinical providers. Let's incorporate these concepts as part of the underlying foundational knowledge and experience that they get.
Great, thank you.
And could I add one thing to it too? In the earlier panel, I spoke a little bit about credit and a focus on serving the in-state versus serving self. And I think we got to be more self-effacing in that regard. And the other piece on secession, oftentimes I think we view secession through the wrong lens. Secession is not necessarily Admiral Merman is going to be my replacement. Secession is but a bridge to a process, to get the best next person. And so I hope we're looking at secession through that lens as well.
Thank you. Lori, we have a question? Okay, great.
Good afternoon. My name is Paisley Williams from KC Care, the prevention manager there. And I just wanted to know what syndemic approaches are you all creating or working on with religious leaders? This is not only just, we're supposed to be in a room, we're healthcare professionals, but what about those where the topics that we're talking about, advancing health services, are not aligning with their calling? They're not at the table. I don't know if they're here. So how are you all creating syndemic approaches with religious leaders, Black and brown in particular, because we're not talking just about high blood pressure and diabetes in this room. So, and what has been your success to it?
Yeah. Could I start that one? Is that okay? Okay, I'm going to go the rest of the show. Religious leaders are one of the sectors in our 12 sectors. I would tell you that in our coalition model, the most prevalent sector is law enforcement because they are looking for solutions. The least populated sector is that of religious leaders, stigma, judgment, and we're actively seeking religious leaders. So we've added a religious leader to our board, our national board. We've added a religious leader to our coalition advisory committee who's helping me to recruit other leaders. I'm also asking folk with lived experiences. One of the things is so stigmatizing to have had lived experience that people are hiding. They're in the dark, and there's people amongst us who we don't even know had lived experience. And so I'm asking folk to trust sharing their experiences so that people might get a new look at folk with lived experiences. And I think that if we collectively do what Aaron shared, adding people to the discourse by putting them out in front and showing them. Last week I had Ryan Leaf. You all might remember, this guy was the number 2 overall draft pick behind Peyton Manning in 1998. He was considered the best quarterback in that draft, though he went after Peyton Manning. And he came into the league with an opioid addiction problem, substance use disorder. To the point where he's a millionaire breaking in people's houses to steal their opioids in Great Falls, Montana. He's 6'5", 270 pounds. You can't hide when you're that big, right? But I had him talk to us, and he's been clean for 11 years. And he shared that his father-in-law was in his house a month ago, had a hip replacement, had opioids, And his mind was saying, there's opioids in the house. He's clean 11 years. And so he told his wife, we need to get a safe, an RX safe, to put those opioids in because my mind is speaking to me. I think unless we're exposed to that, we don't understand it. And I think that the more that we have that honest, authentic, open conversation, the better we'll be as a society. And I think that's how you get clergy into the room.
Lucy, you wanted to add to that?
Different from what you were saying. Just thinking a little bit about how local health departments and state health departments also work, but as local health officials, chief health strategists for their jurisdictions, and their job really is collaboration and partnerships. They can't do everything by themselves. And so we're really wanting to support local health departments with their community engagement and community planning processes. And I know we have a long history in the HIV space of informing, strategic plans around HIV with community planning processes. And one of the things NACCHO is doing currently is funding local health departments in partnership with community-based organizations from refugee and immigrant and migrant communities, and really trying to set up sustainable community engagement processes. And that, in many communities, does involve religious leaders. And I'm thinking in particular of our Afghan and Muslim refugees and immigrants who are often finding themselves coming together as communities in mosques and other places of worship, and that those organizations are participating significantly then in thinking about how to reach their communities around health. So.
Great, thank you. I think we have time for one more question. Holly?
Thank you all. And Holly Hagel, UMKC. Thank you all. Several of you brought up the social determinants of health. It came up this morning many times. And we all know that those determinants are fueling the syndemics that we're here to find solutions on. So I went to the magic of Google and just Googled the definition for us. And I want to get your comment really quickly, because I know we're running on time, on broadening the definition from a partner that I'll share from the current definition, which is that they are the non-medical factors that influence health outcomes, which are the conditions in which people are born, grow, work, live, and age, and a wider set of forces and systems shaping the conditions of daily life. That's what's on, I think, Healthy People 2030 website. So a partner of ours recently at the National Institute on Drug Abuse Clinical Trials Network annual meeting, we were all reflecting on and mentioning social determinants of health, much like we have been today. And she says, her name is Jill Kessler. I want to make sure I attribute passing this thinking forward. It's not my own. She's a member, and I hope I pronounce this right, of the Oglala Sioux tribe. And she's focused on quality assurance and regulatory processes for some of the NIDA studies, of which Dr. Amy Campbell, who's here today, leads. So she says, when I hear the social determinants of health, I hear the outcomes of oppression when I think of that. And I would like to invite you to think about maybe adding that. I added it to a recent poster that we displayed at CPDD, the current definition of the social determinants of health, adding to the outcomes of oppression that they're also the vital conditions that are necessary for health and wellness. So what are your comments on that? Thank you.
Real quick, and this is why I really wanted to bring up this Truth and Reconciliation Commission. There has to be acknowledgement in our country that our social environment is actually, and I'll use these words, one of white supremacy. And until we really have some conversations about that, we're not going to be able, so that definition rings for me as long as we're acknowledging white supremacy.
In addition to white supremacy, the issue of capitalism and the forces that really force our people, I consider houselessness to be not only failed policies, but actually an intentional way to keep our folks down and under, not employed, in shelters, in encampments. So I just want to say capitalism acts. But of course, in this world and in this country, if you put capitalism, you're a CBO, you're not going to get funded. perhaps by CDC or by the Hellman Foundation. So I just want to add that. But I want to say that's why it's so important also that as we tweak into this syndemic approach, which by the way, our Native sisters have been doing the syndemic approach for millennia, right? And we just recognize that we don't need the feds to do it. But also that we need to start honing what are those challenges. So when people, I work with unhoused folks for 20 plus years. So when I see SSPs dealing with 70% of the people who are participants being unhoused, you gotta think through how you're gonna do treatment if people are willing and able to do treatment, right? How are you gonna do induction in buprenorphine? If these are all things that I did when I was, managing a healthcare for the homeless, brick and mortar, right? With folks who use drugs who were also, and that really treatment was not a priority for good reasons, because they didn't have money to eat. Definitely not to cope drugs at times, and definitely to deal with all the other violence and impact of living on the street. So I wanna say, those are the conversations that are the hardest to have because they're the real ones, and they go beyond, I always say racism is a tool of colonialism and capitalism. So we stay just also on the, and by the way, I'm one of the people with a lot of my staff that were actually starting to challenge BIPOC, because BIPOC doesn't talk about the Black experience. BIPOC doesn't talk about the Native experience. BIPOC doesn't talk about the Latinx, immigrant, Chicano, Boricua, all our experience of oppression, right? In a country that has kept our people oppressed here and abroad. So, those are my anti-colonial views on this.
Thank you.